there's an evolution going on in patient blood management, and that's very helpful and useful. But I think the evolution is going to lead us to a point at which bloodless medicine is the default. In other words, bloodless medicine is the final stage of evolution of patient blood management. And I'll get to that as I work my way through it and show you how I've arrived at this. I'm not sure many of us have arrived at this thinking yet. You all have who are on this, perhaps all of you have who are on this wonderful call, but I'm not sure the rest of the world has come to this, and they certainly seem to fight it and kick it as they go towards embracing it. Kelly was nice enough to say that I'm an emeritus professor. Oh, come on, let's see if this will advance. Doesn't want to advance. There we go. So you'll now notice that instead of living in Florida, maybe you won't notice it, but I can tell you that it is now 5 a.m. my time in the West Coast of the United States. And I've just moved and retired from clinical medicine to what my wife will tell you is not really retirement, but now I have lots of time on my own. Instead of having to be called to the operating rooms all the time, I have time to think and to write and to do a lot more, I think, to influence the world. So I now live on the far west coast of the United States in Palm Springs, California. It's a beautiful place. That view of the mountain is right behind my house, Mount San Jacinto, and that desert sunrise, I actually took that picture a few weeks ago myself out of the back door of the house. So, you know, I now live in a very beautiful place, but unfortunately a long ways away from where many of you are attending today. So I have some disclosures. As you can see, most or many of them had to do with transfusion and companies and such that deal with transfusion, as well as artificial blood companies. None of them, I think, will have influence on this particular talk. And I'm going to give you the conclusion and use that as an outline for my talk. And the conclusion is that blood is a complex organ system. It is perhaps our ultimate organ because everything in blood touches every other organ in the body at least once a minute if you have normal circulation. And I think that single concept is the entire misunderstanding of where we've come to today, which is that medicine doesn't really teach about blood as an organ or as an organ system. They teach little snippets and little bits and little pieces, and we focus an awful lot on hemoglobin and oxygen carrying capacity, but we don't talk about the complex interactions. And to me, the beauty of what I like to embrace in medicine and what I see as God's work in medicine is biologic complexity. And so the more and more we teach about the biologic complexity, I think the more we'll understand blood as a complex organ system. And I'll put it to you that we do not transplant organs until they've completely failed. Nowhere do we transplant a liver transplant or a heart transplant until that organ has failed. We can't go to the refrigerator and just grab a little bit of liver to throw it in when somebody's liver enzymes are elevated, and on it goes. So we're in a situation, I think, where medicine's teaching has had profound misunderstanding of blood as an organ. For over 100 years, I think medicine has had it wrong, and we have really misled ourselves in terms of both the philosophy of where we ought to be going and ultimately using transfusion as a crutch rather than as a full understanding of the organ. So the concept of bloodless medicine, I think, eventually, and it's going to be years and years and years of hard-fought teaching by a number of us, many of you on this phone call, that the concept of bloodless medicine has to become the default position for all of medicine. We're a long ways from there, as you know, but I think that's where it has to go. The World Health Organization has put this wonderful call to action through Axel Hoffman and other people who some of whom are on this call, who've been involved and have been pressed forward, and it calls for all 192 member countries to endorse and institute patient blood management. That just came out in October 2021. If anybody hasn't read it yet, if you haven't sort of mentally endorsed it yourself, please do. I think it's one of the finest articles I've ever read because it's a profound summary. It's compelling, and it flows beautifully as well. And you can just plain read it without having to have profound knowledge in our specialty. It's meant to appeal to governments and to be a briefing paper. It talks about requiring multidisciplinary patient quality focus. And that's where we've evolved to now. Whereas, and I'll go through a timeline for you in terms of development of patient blood management, but we're now finally focused on the patient as the center of our universe. Isn't it amazing that in medicine we had to get to this point? That we had to, after 120 years, actually finally get to the point and saying, well, it's the patient that really counts. And what would you do for yourself? So patient blood management has evolved from really the AIDS crisis in the 1970s and 80s, and I'll say it from those 1970s, because it was really the 1960s and 70s that was the hepatitis crisis, which led to the AIDS crisis. And that led to understanding transfusion safety, or a focus on transfusion safety, and eventually blood reduction and blood salvage, and then whole healthcare total patient focused on quality. And that's where we are now. But there's still a lot of fighting and pushing back and saying, well, it's too hard to do that. What do you mean it's too hard to focus on a patient? Really? What would I want for myself? So patient blood management is an evolutionary stop. It's an evolutionary branch on this branching tree that will eventually become bloodless medicine, which is where we have to be in the future. So has patient blood management matured? Absolutely, it has not matured. It's in some ways in its own infancy, and that certainly the number of centers in the United States who are getting on board is increasing, but it's by no means even established itself as the default position for centers in the United States. And when you think about it, the patient blood management, which is still focused on ways to reduce transfusion by treating anemia and stuff, it's still fundamentally different than bloodless medicine. So patient blood management in and of itself still assumes that transfusion is a default position, or that it is something that we can try to limit, and it merely fights back to say, let's not get there. Let's not get to a trigger. But it doesn't say that the very concept of a trigger to begin with is a non-starter, is an incorrect concept to begin with. So we've got a long ways to go. So I love this slide, and I'll ask you what you see. And what you see is not always the truth. Obviously, in my country right now, we have a lot in politics about what you hear is not always the truth. But how many of you see horses? How many of you see zebras? There's not a horse in this picture. These are all zebras. And if you look at it, the horses are just the shadows. So squint at it, look at it carefully, and then think about it. Think about what we've done with hemoglobin. Think about what we've done with transfusion. Do we really understand the biologic complexity of how oxygen is delivered? Or have we just simply seen the obvious thing? The bright red that's in front of our faces all the time, the bright red that is the shiny object that is so easy for us, maybe 100 years ago, to ascribe all kinds of different things to. But when it comes to really in-depth knowledge, we have not, as medicine yet, embraced that. And as a physician who does an awful lot of research, specifically in this area, I think it behooves us as physicians to embrace the complexity and to say, well, now, wait a minute, maybe I really don't understand everything, and maybe I'm just seeing the shadows and not the absolute truth. So transfusion, and you can make this timeline more and more and more complex, and people can put many more things on here. But, the first transfusion in 1667, and shortly thereafter, the outline of transfusion by the Pope, was the start of all this hundreds of years ago. But it goes all the way back into Western civilization with a fascination with blood and the Romans and stuff. But really, the modern transfusion world begins about either in 1818 or 1900, depending on which one you want to take. And of course, it gets exploded by the possibility that we can take this substance, blood, and we can put it in a refrigerator. And for all intents and purposes, in the early 1900s, it looked the same when it came out of the refrigerator as when it went in. Okay, so it's a little darker. It's got a little less oxyhemoglobin. But then, of course, in the world wars and the Spanish Civil War, it really exploded in its utilization. But what really exploded was not just the utilization of red blood cells, but it was the utilization of plasma as a volume expander that saved so many lives. And what was, in terms of transfusion, was soldier to soldier and whole blood. But I find fascinating, and I've had talks with the people who first described ARDS, that it was in Vietnam, in the Vietnam War, the United States, when the United States was involved with Vietnam, that really large-scale banked component blood, in terms of red cells, was first utilized on a major scale. And is it any wonder that at that point is when the first descriptions of ARDS came out in shock? Was there ARDS in World War I and World War II? Yeah, probably, but with shock lung and stuff. But I've asked the people who were there on the front lines, and they said maybe it really was trolley. Maybe that was ARDS manifesting as trolley. But it goes on and on and on. There are signals that we in medicine have preferred to put our blinders on and not see the zebras, but see only the horses walking by as shadows. Hepatitis, for example, around the world has been a huge problem with transfusion, as have been many, many other infectious diseases, and still are today. But hepatitis was first described in transfusion in 1947. That's interesting. That was the same year that the call came for everybody to be transfused at 10%, at 10 grams per deciliter or 100 grams per liter. That was the exact same year that we first proposed a trigger that was based on nothing. And that trigger, that 10 grams per deciliter, continued until the AIDS crisis. Nobody ever asked, with 10% risk of hepatitis conversion in the United States over that time from 1947 until 1987, 1988, 40 years, nobody ever once asked, is the trigger right? Or does the trigger really signal anything? Is the trigger for transfusion just a useless number that, because we trying to be so simplistic, we're going to hang our hat on a number and, oh, it just happens to be a round number that a village idiot can remember. So and now we live in a world where we've changed the trigger, and we think we're pretty cool because we've reduced the trigger. But the arguments can continue today. Is 7 to 8 grams the right trigger? Is 6 grams the right trigger? What's the right trigger? I'm one of the few people in the world that said there shouldn't be a trigger. The trigger of using hemoglobin is a false god. It's the horse. We need to understand the zebras walking through the world. But now we've gone from the HIV crisis to cost containment, transfusion reduction, in a profound effort to try to reduce utilization of blood that might or And we've done a great deal to increase the safety in terms of transfusing mostly HIV, but also a few viruses. And I'm going to say that a very few viruses, because we only test for a few viruses compared to the numbers of millions of viruses that are in there. And now, just now, we're starting to talk about, well, maybe we should treat anemia. What a unique concept. Maybe we should treat anemia. How long along that continuum did it take us to get to this point? But nobody's yet talking about, do we really understand what we're doing with blood? And can we give a unit and not hurt somebody? Or maybe giving a unit isn't such a great idea to begin with. I stole this slide from a presentation that we just gave the other day, which is, and many of us are talking about it, is PBM is in the midst of a cultural shift from a transfusion blood component focused effort to a patient blood management focused, patient-centered team sport. Team sports are much more difficult than tennis or swimming, where the only thing you have to depend on is yourself. If you have to depend on 5 or 10 other people all working together to focus on a patient, there's an awful lot of communication. And communication in some of our complex medical centers isn't the best, and it's difficult. So there's no data in support of transfusion making a large difference in outcome in mankind. And there are now, there are very few references that speak to the positiveness of giving a transfusion. And there's extensive data, of course, in retrospective databases demonstrating association between transfusion and adverse outcomes. But yet we still worship it as a trigger point, and now all we do is argue about what's the right trigger. Well, that to me philosophically is, again, the horses and zebras. What are you tilting at? What kind of windmill does Don Quixote chasing after that isn't actually real to begin with? There are now 68 randomized trials of liberal transfusion versus less liberal transfusion. Yeah, and the transfusion triggers between those are small. But how many lectures have I attended? How many meetings have I attended where somebody says, well, you really can't do a transfusion versus no transfusion study? Of course you can. All you have to do is have the fortitude to understand and put forward a randomized controlled trial of, pick whatever transfusion trigger you want. I don't care. But then do it against the finest of patient blood management. We could actually do that. And I swear to you that if you did that, you would find out that actually bloodless medicine, or using all the techniques we have to never get to that transfusion, has a better outcome. I believe, but nobody's done it yet. Instead, we continue to do these randomized controlled trials. And I, in the last few days, have heard that another one's coming, Trick 4, okay? Trick 4 is a Canadian study to look at outcome after heart surgery. If you focus on just the right patients, can we find that transfusion might make a difference? Well, in 68 trials, transfusion didn't make a difference. Why are we still looking for just that one more study that might justify how we've done it wrong all this time? Is that insanity? This is what Einstein said. The definition of human insanity is doing the same thing over and over again in hopes of finding something different. Wow. But we're doing it because we have this deep-seated belief that somewhere transfusion is good. If we could only find that, if we could only find, and if we could only turn over that one rock where the piece of information is hiding underneath that says, you did it right for 120 years. It doesn't exist. We need to understand biologic complexity and dig into it and realize that any trigger is not the right trigger, and that we're tilting at windmills and going after things the wrong way. I will dive down a rabbit hole and go off script for just a second, but I showed you that beautiful sunrise at the beginning from Palm Springs, California. Well, Palm Springs has this monstrous mountain right behind me, and come to find out that Einstein spent a fair amount of time here in Palm Springs, and he would climb that mountain. He would climb to about 2,000 feet, sit on one of the rocks, which happens to be on one of the trails I like to hike out here, and he would watch the sunrise, because he had a clear view of the Earth's surface, and he could see the light emanating from the sun. And from that, he got inspiration for some of his theorems on light and energy and mass and stuff. It isn't where he wrote E equals MC squared, but it's where he came up with a number of his thoughts. It is to me very inspiring to go to that spot and say, wow, Einstein sat here and watched the sunrise. So oxygen delivery is oxygen delivery basically dependent upon hemoglobin concentration? Of course it isn't. And I've given lectures to all of us on this. There are some monstrous assumptions we've made over the 120 years of this. Oxygen delivery is not dependent on hemoglobin concentration. More hemoglobin is good. That's another assumption. More hemoglobin is not necessarily good. And the number one assumption is that transfusion improves outcome. How many times have we proven that false? And bank blood is equivalent or a useful surrogate. Well, now we know it isn't. And replacement of lost blood is the right thing to do. And we've argued over these triggers. What are the next big assumptions? What are the next big things we'll come up with? What is it if we all assume? There's a risk if the assumption is wrong, and medicine has made these assumptions forever. And that's what the assumption means, is it makes an ass out of you and me if you assume and you are wrong. And rather than continue the dogma of just trying to prove that the assumptions that we've made for 120 years are right, why can't medicine go back to the very beginning? And so this is one of my favorite papers by Aurier, and Aurier's written a number of good things. But is it really dangerous, anemia or transfusion? So now we're focused on the anemia. Let's get rid of the anemia. But the focus on this is a nice medical discussion of statistics and looking at the data. But the philosophy of, are we making the right assumptions? Or we shouldn't be making any assumptions, but have we done the right research and looked at the data from the right angle, is still not there. Aurier has taken a huge effort in trying to pull people to look at the data correctly. That PBM is not the end of the evolution. PBM is just a stop on the way, perhaps, to a full-on change in our thinking. And I think the people who are listening today are some of those who are capable of forcing that change. And I think number one is a complete understanding of blood as an organ. I'm going to show you how complex and beautiful I think blood is. And why is it only people like me who spend their entire life studying this get to this understanding? It's because we don't teach it in medical school. We give one or two lectures about hemoglobin. We give one or two lectures about various cell types. We give almost no lectures about coagulation other than showing the same pedantic, stupid protein cascades over and over again. And there's not a single medical center in the world I know of that either talks about the transfusion decision and when and oxygen transport to the depth that physicians need to know to make the right decisions. So transfusion does affect outcome after surgery. Less is more. We know that, and we know that immunosuppression is huge. When is it that there's up to a 7-fold increase in adverse outcome by giving a therapy, yet everybody continues to want to study why that therapy is just so right and so perfect? We know lots about pulmonary dysfunction, and on it goes. I'm going to move past that. So why do we just continue to follow those lemmings off the cliff? What if medicine with blood transfusion had it wrong right from the very beginning? What if the basic premise itself was basically flawed? I think it is. And there's few of us who've been willing to stand up and say that. We've all been nice to go and look at the data as Arieh Shander has and try to convince each other. But it takes a heck of a lot to look in the mirror and say, I had this wrong from the beginning, and I need basically to start over. And the start over is for all of us in medical school to embrace and teach that blood is an organ. We should have as much time in a course series as does biochemistry or other physiology, and really take a deep dive into how much this makes a difference. When the number one therapy in Western medicine in the United States is a therapy that doesn't work, then we're somehow teaching people the wrong thing. Blood is a complex moving fluid. It has over 2,700 different proteins that we know of today, multiple different cell lines. They all interact, and the interaction of how they relate to each other in normal physiology and disease is beautiful. And we need to teach that. Blood touches and it regulates every other organ system. And so we can break down some of those silos. We can do some teaching, and we need to affect it and understand it, that blood is an entire ecosystem. And unless you understand how each part of the ecosystem feeds back into the entire ecosystem, you cannot maintain a healthy ecosystem. So blood and the vascular system are an organ. They are mature and they're balanced ecosystems. Now, here's the problem. Once an ecosystem gets unbalanced with challenge and perturbations, you can't just give part of the ecosystem back, especially a dysfunctional part of the ecosystem back, and expect everything to be normal. So once the ecosystem is dramatically disturbed, it's hard to restore homeostasis. And that's where we should study, is thinking about this, the forest through the trees, and how do you restore the forest when there's been a forest fire or something else. Single interventions cannot bring things to normality. You have to be able to understand the ecosystem and look at micro and macro interactions, and do not oversimplify. Can we have a transfusion trigger? How much profound oversimplification is that? And it is dead wrong right from the beginning. So, just if you, again, stand back and you take a look at it, we focus on blood and its oxygen carrying capacity because that's obvious, right? There's millions of RBCs. There's so much hemoglobin in each RBC, but how many of us really understand how that actually works? Same with albumin. Albumin is a fascinating protein. Look at all the things it does over on the right-hand side. When I go into the operating room, the only thing that anesthesiologists and the surgeons and perfusion and stuff want to talk about is water flow between the vascular system and the extravascular system based on how much albumin. That is so minor compared to all these other functions that albumin has. And the biggest thing that albumin probably does is that it's the most profound antioxidant. So what does that have to do with how well red blood cells function? Well, the redox state of the blood, how many free electrons there are bouncing around, actually has a great deal to do with whether red cells are flexible, they're not flexible, they're band 3 protein, which sits on their surfaces and tells whether the cells are senescent and they need to be scrubbed from the circulation. So the environment that the red cell flows in and how many free electrons are available, how much oxidative stress there is, determines how well the red cell interacts with the endothelial cell. And here's this guy, albumin, who happens to be the best buffer that we have. How many physicians understand that and really can embrace it and really say, if we get the things right, maybe we can have a different view that we shouldn't just waste this precious fluid and throw it on the ground. How about taking the idea that when we do surgery and we have lap sponges or we have Ratex or other ways of soaking up the blood, most of that gets thrown in the trash. Why is it that nobody has yet invented an automated, proper washing machine to extract that blood and get it back and get it into the patient? It's because we just think this is a wasted fluid and we can throw it away. So the complexity, and I'm already beginning to get towards over my time, but you can see that there's complexity and complexity. Just the flow shear stress, the physics of the cells themselves. Why don't we teach that? We don't. We just say, here's your one lecture on hemoglobin, and oh, by the way, when you get to the ward, some gray-haired old man will tell you when to give a unit of blood. That's absolutely just wrong. And I've spoken to you before that I think red blood cells have evolved in mammals to regulate tissue oxygen levels, not that more red blood cells increases oxygen delivery, because it doesn't. Because what happens is that we have a vast excess of red blood cells for the just-in-time FedEx or DHL or UPS or whoever is delivering in your neighborhood, just-in-time delivery. And the normal level of hemoglobin and hematocrit exceeds the need for critical oxygen supply by at least 5-fold. So you can, the old time excuse, the horses versus the zebras discussion is always, well, we evolved that way in case the saber-toothed tiger bites your butt. Well, no, we didn't evolve that way because of that. We evolved that hemoglobin and the amount of hemoglobin we have as an evolutionary advantage has something to do with an evolutionary advantage other than just giving more oxygen to the tissues. More oxygen to the tissues kills the tissue. My tissue wants exactly the same amount of oxygen all the time. And if you increase the amount of oxygen 5-fold to my tissues die. Oxygen is a profound toxin, and the red cells are there to regulate it and to normalize it, but not to provide extra. So the normal hemoglobin and hematocrit, I think, has evolved as a regulation of vascular tone, shear stress, nitric oxide flux, and signaling, profound, fascinating signaling to endothelial cells. Did you know that RBCs are important to coagulation? Here's all the effect that RBCs have upon coagulation. Why don't we teach that in medical school? It's because nobody cares to have the focus upon it. And here's some of the interactions with endothelial cells. We need to teach it. Coagulation is inflammation. We are now learning that in COVID, that coagulation is inflammation, and the two go backwards and forwards profoundly. And inflammation is complex, and coagulation is the first step towards inflammation. And platelets are the gatekeepers for both inflammation and coagulation. And we're back at the level of talking about chickens and eggs. We're back even in the COVID world, we're all focused on, well, these are platelets that are causing these reactions, and gee, this is a pulmonary disease, and the disease goes on and is killing us rampantly because we're not willing to embrace the biocomplexity that we should be embracing. And there are over 850 forward activating and backward controlling reactions in coagulation. You need a computer-based model to be able to even begin to understand it. But yet we teach the same pedantic little coagulation cascade that was worked out in 1957s. Wow, just so more and more things about red cells and why we haven't got it correct yet. So, in the AIDS crisis, we came out and realized that your own blood in the operation is your best blood. And so that's good. But how about if we didn't waste your blood to begin with? How about if we said that bloodless medicine, in other words, not ever having a dependency on some external source, is the number one thing that needs to happen. I'm going to go past these vascular tree things because I'm going to get bogged down. But there's a standard coagulation cascade, maybe more complex than usually what we teach. But what we don't teach is all these other layers and layers and layers of complexity. Okay, can every physician understand all the depth that I'm talking about? No, but we need to go far beyond how we've taught it in the past. And we absolutely have to teach that transfusion does not increase oxygen delivery. As a matter of fact, in all the studies that have ever been done, there are at least 10 to 1, or maybe 20 to 1, if you just weigh the amount of paper, that show that oxygen delivery by transfusion either does nothing or decreases oxygen delivery to tissues. There's only 1 or 2 that have had a hint that maybe it somehow increases oxygen delivery. Yet we continue to try to find those studies to justify our belief system. And there's a very famous quote, and I'm going to get it wrong. It says something like, when your beliefs are questioned, everybody gets to work trying to prove their beliefs. And that's, I think, where we've come to if we've looked at the system as a whole, rather than just getting down and embracing the beauty and the complexity. Here's 2,3-DPG. Why is it that most physicians can neither understand 2,3-DPG, where it comes from, where it goes to, or how it's affected when we put blood into a bag and put it in a refrigerator? It has to do with oxidative stress, and it has to do with glutathione, and it has to do with albumin, and it has to do with all these complexities. It's not just so simple as you put it in a refrigerator and you pull it out the way we did 100 years ago, and things are just fine. Isn't it amazing that Jehovah's Witnesses actually do better, or at least as well, until you get them to the point of critical hemoglobin delivery, which is at about 3 to 5 grams per deciliter. Isn't it amazing that they do better than if you let the physicians actually do what the physicians do, which is argue over a transfusion trigger? Transfusion triggers have to go away. Patient blood management is just a stop on the road to getting to understanding the biologic complexity and understanding that that where we're at is to go to patient blood management. And I think I'm going to try to wrap this up because I'd rather take some questions here at the end than just keep going. I've always been a heretic. Heretics get burned at the stake. I've been burned at the stake more than a few times for me daring to say that, did we do it right? Did I do it right? Yeah, I transfused at 10 grams per deciliter for a large part of my career. I transfused at 7 grams per deciliter for a large part of my career, thinking that, gee, I was pretty good because I was one of the first guys to endorse that. But now I'm saying, wait a minute, that's not right either. Wait a minute, that's not right. What's right is to understand the complexity and say that a trigger doesn't exist. There is no such thing as a trigger, and we're all worshiping false gods that mean nothing. We're just repeating the same thing over and over again. Heretics attack institutions that are basically on shaky grounds, and then they suffer because they dared to tell the truth that they saw it different. Does the earth revolve around the sun, or does the sun revolve around the earth? Galileo paid a price for that. I pay a price for saying patient blood management is partially on the way, an evolutionary on the way to where you guys know it is, which is bloodless medicine. If the truth is trolled, sometimes the train goes off the tracks, and sometimes the train has to be rebuilt, or the tracks have to be rebuilt. And the understanding to get from point A to point B is so much more. So I'm going to conclude there and say blood is an absolutely complex organ. You saw I went by a lot of slides, which just merely proved it over and over to you, that blood is a complex organ. And I've had people say to me, well, Speiss, not every doctor can understand what you're talking about. Well, we have to, because that's how we live. And to simply throw our hands up in the air and say, well, I can't understand it because it's too complex. Why don't I just give up and not be a doctor to begin with? Why not say the truth is there somewhere, and we've been too simplistic, and we need to get more and more complex, and really embracing bloodless medicine as saying this is a vital organ system that we can't just throw away, and we can't just easily replace, and we can't argue about the triggers. And yes, we need to treat anemia, and yes, we need to be focused on patients, but we need to understand that there's nothing else that's as good as what flows in our blood to begin with.